According to data from the National Aeronautics and Space Administration, 2023 was the warmest year ever recorded. Each month from June through December of that year set a high-temperature global record for that respective month. And last year was not an anomaly. The 10 warmest years in the nearly 175 years we have on record have all occurred during the last decade. On our current global greenhouse gas emissions trajectory, more frequent extreme heat events are expected to become increasingly common worldwide, and humans are feeling the effects of this heat. Heat-related mortality among persons over age 65 has increased 85% from the 1990s to the past decade. In this video, we'll cover the clinical signs, symptoms, complications, and risk factors associated with heat-related illnesses, before discussing how best to support patients with these illnesses and how to prevent them in the first place. We regulate our body temperatures through sweating, vasodilation, and behavioral modification to maintain an internal core temperature of around 37 degrees Celsius, or 98.6 degrees Fahrenheit. However, a person's environment and activities in interaction with their underlying physical condition can interfere with or overwhelm the body's thermoregulation ability. It's worth noting that heat exposure is linked to an increased risk of medical problems in general, such as cardiac events, stroke, respiratory problems, pregnancy complications, renal and electrolyte disturbances, and mental health harms. But today, we will zoom in on acute heat-related illnesses and how to manage them. Heat-related illnesses can be categorized into those that are mild, moderate, and severe. You may be most familiar with some of the milder acute heat-related conditions listed here. They include heat rash, heat cramps, heat edema, heat syncope, sunburns, and burns from contact with hot surfaces. Heat exhaustion is characterized by profound fatigue, weakness, nausea, headache, dizziness, and sometimes vomiting. It is caused by a decrease in body water content, or blood volume, due to water or salt depletion from heat exposure. Body temperature may be mildly elevated. Importantly, unlike in heat stroke, mental status is normal. Treatment for heat exhaustion can involve removing the patient from heat, stopping any activity that is generating excess metabolic heat, and encouraging rest in the supine position. Evaporative cooling can be initiated, which can entail misting or spraying cool water on the patient, and using fans to drive evaporation. IV and oral rehydration are also part of heat exhaustion treatment. If the patient does not respond to these measures within 15 to 30 minutes, further evaluation is warranted to search for alternate diagnoses. The most severe heat-related illness is heat stroke, which is characterized by the triad of hyperthermia, neurologic abnormalities, and recent exposure to hot weather, physical exertion, or both. Heat stroke may progress to multi-system organ failure and death if not promptly recognized and treated. Classic heat stroke follows environmental heat exposure and frequently affects older individuals with underlying health problems, which compromise their behavioral and respiratory compensatory responses to heat. These patients may also be on medications that make thermoregulation more difficult. Exertional heat stroke, which follows physical exertion in the context of heat, can afflict otherwise healthy individuals engaged in extreme exercise, like running a marathon, often but not always in the setting of concomitant ambient heat exposure. With exertional heat stroke, sweating is common, whereas in classic heat stroke, patients' skin is often hot and dry. In either type of heat stroke, patients may experience tachycardia, tachypnea, and hypotension. The change in mental status best differentiates heat stroke from heat exhaustion and other milder heat-related illnesses. Patients with heat stroke may be confused, weak, dizzy, delirious, combative, agitated, exhibit slurred speech and vomiting, or be stuporous or obtunded. In extreme cases, patients can have seizures or sphincter incontinence. In a patient with these symptoms, the differential diagnosis also includes sepsis, ischemic or hemorrhagic stroke, and toxicologic or endocrinologic emergencies, among other conditions. In addition to a detailed history, core body temperature should be immediately checked on any patient with possible heat stroke, because rapid intervention can prevent serious complications and death. A patient with heat stroke should be removed from heat, and cooling should be started as soon as possible. If a patient is outside the hospital without access to pre-hospital cooling techniques, pouring copious amounts of cool water over the patient, misting them thoroughly, and fanning are recommended to begin evaporative cooling. When treating for heat stroke, first check and stabilize the ABCs, or airway, breathing, and circulation, and then rapidly cool the patient to a goal core temperature of 38 to 39 degrees Celsius, or 100.4 to 102.2 degrees Fahrenheit, ideally within 30 minutes of presentation. The most effective cooling methods are cold water or ice water immersion. If this is not possible, cold fluid infusion, ice packs to the neck, groin, and axilla, and evaporative cooling with misting, spraying, and fans are alternative strategies. Core temperature monitoring throughout these treatments is imperative. Benzodiazepines may be used to control agitation, discomfort, and shivering, but they are not a replacement for cooling. And you may be tempted to reach for medications you would use to treat fever, but antipyretics are not recommended for heat stroke, as they are ineffective in this context and can aggravate coagulopathy and end organ damage. Keep in mind that patients who are successfully cooled are still at high risk for organ failure and generally require management in an intensive care unit. Several factors, including sociocultural ones, influence an individual's risk of extreme heat exposure. Urban heat islands, or areas with limited green space and with densely built infrastructure that emits heat, can be 0.6 to 3.9 degrees Celsius, or 1 to 7 degrees Fahrenheit, hotter on average than outlying areas. In the U.S., largely owing to historically racist zoning practices such as redlining, low-income communities of color are disproportionately represented among residents in these areas. Whether high temperatures impact health also depends on the ambient temperatures that a person is accustomed to. Heat illnesses occur at lower temperature thresholds in regions where temperatures are typically cooler. Outdoor workers are at particularly high risk of heat-related illnesses. According to data from the Centers for Disease Control and Prevention, crop workers die from heat stroke at a rate nearly 20 times that of U.S. civilian workers overall. Besides direct exposure to heat and extreme physical exertion, workers may be required to wear protective clothing that traps heat and may have little or no ability to control their environment or working conditions. There is currently no dedicated U.S. standard addressing occupational heat exposure, though efforts are underway to create one. The National Institute of Occupational Safety and Health has published criteria for a recommended standard. Individual factors also contribute to the risk of heat-related illnesses. Risks are higher in those with underlying medical conditions like chronic heart, kidney, or lung disease, as well as those who are obese, those who are very old, very young, or pregnant, and those who have cognitive impairments and disabilities. Those with substance use disorder or other psychiatric disease are also at risk. Socially isolated persons and the unhoused are especially vulnerable during a heat wave. Certain medications can also cause problems. For example, anticholinergic drugs that can decrease sweat production, antipsychotics that interfere with hypothalamic thermoregulation, diuretics that may increase the risk of dehydration, weight loss supplements that may increase metabolic heat production, and many others. Alcohol and recreational drugs, particularly stimulants and sedative hypnotics, also pose increased risks, owing to several effects including impaired judgment and alertness and dehydration. Systemic change is needed to mitigate the harms of climate change and create population-level protections from heat. But day to day, what can clinicians do to protect their patients from heat-related illnesses? Expert guidelines recommend that before the warm season, clinicians should identify heat-vulnerable patients and discuss strategies for reducing risks with them and their caregivers. Measures that may sound intuitive can be life-saving. For example, providers should encourage patients to keep living spaces cool on hot days. Options include evaporative coolers, air conditioning, heat pumps, or fans. Keep in mind that some of these release greenhouse gases, most notably air conditioners, and that fans are not effective above certain temperatures and humidity levels. For some high-risk persons, temperatures above 37 degrees Celsius or 98 degrees Fahrenheit may be too hot for fans to be useful. Providers can encourage patients to check a weather app for the heat index, which incorporates factors like humidity, to best assess heat risks day to day. On hot days, high-risk persons should limit outdoor exposure and activity, increase water intake, and monitor for symptoms of heat-related illness. Some individuals may not be able to afford their energy bills or may not have access to adequate cooling equipment. For such persons, a heat plan should be developed that includes location and transportation options for hot days. When feasible, sending a social worker or caseworker to check on vulnerable patients can be helpful. Several states, for example, California and Washington, have local regulations designed to protect outdoor workers, like guaranteed water and shade breaks, and patients in such states should be informed of these protections. Clinicians can also advocate for additional protections at the policy level. In addition to public health measures aimed at reducing risks, rapid action to reduce greenhouse gas emissions is needed to prevent further increases in morbidity and mortality due to heat exposure. In the meantime, clinicians can support individual patients with preventive counseling and therapeutic measures when faced with illnesses related to extreme heat. Much of the information presented in this video comes from an NEJM clinical practice piece by Dr. Cecilia Sorensen and Dr. Jeremy Hess, which was part of the Fossil Fuel Pollution and Climate Change series. Examples of other resources addressing extreme heat are listed here.